Good morning. The Legislative Task Force on Aging is called to order. A quorum is present.
Recording in progress.
The Legislative Task Force on Aging is called to order. A quorum is present. It's great to see so many out here today to participate in the work that we are endeavoring. Our first order of business, and I, by the way, am Vice Chair Senator Kelly Morrison. With the gavel today, with me is Chair Ginny Cleavorn. Our first order of business is to adopt the previous meeting minutes. Those minutes are in members' packets. All in favor of adopting the minutes, please say aye. Aye.
Aye.
All opposed say nay. The meeting minutes for our August 24th meeting are adopted. So today we're going to start with a presentation from the Minnesota Department of Human Services. So I will welcome Natasha Mers, Assistant Commissioner for Aging and Disability Services, and Carrie Benson, Director of DHS Aging and Adult Services Division, to the table. Welcome. Please introduce yourself for the record and proceed with your presentation.
Wonderful. Thank you, Senator Morrison. Good morning, everyone. My name is Natasha Mers, and I am the Assistant Commissioner for Aging and Disability Services at the Department of Human Services. And happy to be here today with Carrie Benson and to share kind of an overview of programs that support seniors and older Minnesotans and share some important statistics and some of our strategic priorities with you. So we do have a little PowerPoint that we'll get up and running for you. In just 1 second. Okay, wonderful. All right, so our agenda for today, if you want to advance, please, Carrie. Great. So we're going to talk about kind of organize the information we'll be presenting to you across the strategic priorities that really guide our work in the aging space. And you can see those strategic priorities up there for you. And we're really happy to share, some of the work that we've done, some of the work that remains done, and we're also really proud that Minnesota is consistently ranked at the top of states for its long-term services and support system. But we should never rest on our laurels, and having said that and being very proud of that consistent statistic, we also know that we have a lot of work to do together here in Minnesota. Obviously, our population and demographically is shifting and skewing towards aging. We're seeing that shift there. Older adults of color and Native American elders experience disparities in access to services and service outcomes, and that's a really important area of focus and emphasis for us at the department. And we also, in general, know that we see everyday examples of ageism in our society, and we really want to be a part of shifting the narrative away from ageism and towards really seeing our seniors and elders as valued members of our communities with a lot to contribute. And that if we don't figure out how to do that and fight ageism, we're going to be missing out in a big way as our society and demographics shift forward. So throughout the presentation, we'll share with you areas that we've identified and opportunities to build on what we've already done to improve our system. And, we'll offer some ideas and some next steps and really look forward to your input throughout this entire process. Next slide, please. Okay, so just a little bit of demographic grounding. Know that you all heard from the state demographer, but wanted to just ground us in some of those statistics. So the total Minnesota population that is age 60 and older is about 1.3 million, and about 8% of those, or a little over 100,000, are people of color. And recently, for the first time, Minnesota's 65-plus population eclipsed the number of school-age children. And we also wanted to point out or acknowledge that these demographic shifts aren't happening equally or uniformly across the state, that there are significant differences in some of these statistics in greater Minnesota versus the metro area. And that's an important factor when we think about building or maintaining or improving a statewide system, is really paying attention to that geographic diversity and what that means in terms of accessing services and having provider networks that are available. Okay, so another really important statistics, we're going to shift over now from kind of the general statewide view to some of the services and programs that the department designs and administers in collaboration and partnership with our provider agencies and the Board on Aging. So about 1 in 5 older adults receive home and community-based services. And I want to take a minute to define that term in case, because it is, you know, a very broad term that has that may be confusing for people. So when we talk about home and community-based services, or you might hear me slip and use the acronym HCBS, you're invited to correct me if I don't, because we love our acronyms at the department, and we are also always trying to get better at that so that we're more clear in our communication. But home and community-based services include services provided under the Older Americans Act, and Ms. Benson is going to give you guys more information about what those services and supports are, and I'll be the one more focusing on the Medicaid and the waiver programs, and I'll get into more of that later. So when we talk about home and community-based services, again, includes the Older Adult Act services that are delivered through our area agencies on aging, and more to come on that, as well as means-tested HCBS programs. And when I say means-tested, I mean generally Medicaid or medical assistance services. So you have to qualify for Medicaid or in Minnesota, medical assistance in order to access that particular set of services. So in this context, HCBS is kind of the whole umbrella. And generally, services that we administer touch about 200,000 older adults each year, and about 32,000 receive our sort of most intensive, high-intensity service sets in their own homes or sometimes in assisted living through the Elderly Waiver Program. Sometimes you may have heard of it called Customized Living is the name of the service that pays under the Elderly Waiver. And so as you can see, this is the percentage of people that receive services in that assisted living setting is really small, about 3% compared to all the other services that are delivered in other parts of the community. And so this slide just is a breakdown of, a different way to show that most people receive services in their own home. Older Americans Act services are not, they can't be delivered in a facility, so there's always going to be 0% there. But I would draw your attention to the age breakdowns for elderly waiver and alternative care, and how many are living in a facility, which would be assisted living facilities in this particular context. This does not include nursing homes. So we'll be focusing today, for today's presentation, on the home and community-based infrastructure. Nursing homes is sort of a separate set of services and supports delivered under Medicaid or private pay. And we've provided some data here that may not be super easy for folks to read here, but want to drive home some of the points, and we can certainly, I'm sure this PowerPoint will be available publicly and as needed, so you can take a deeper dive. But we do routinely collect data using a national tool called the NCI that really helps us understand the person's experience receiving home and community-based services. Some states participate in the NCI and some don't, or some may participate in part or the other. Minnesota has a pretty robust NCI data collection infrastructure for older adults and people with disabilities, and so we do have a lot of that information that we've collected year over year. So most people on average in Minnesota do say that services help them feel in control of their life and that it's helpful for them. So it shows positive outcomes, but again, wanted to acknowledge that when you disaggregate this data by race and ethnicity, you do see some negative disparate outcomes for seniors of color and Native American elders. So just want to keep acknowledging that that's something we really need to continue to work on and call attention to from a public policy perspective. Same thing, kind of the same point, same data set. People generally say that services help people live the life they want. And so you can see the Minnesota averages there compared to the national averages. And similarly, these services help people to do the things outside of their home as much as they care to do it. So really trying to support the life in the community that leads to contributions to community and real authentic membership that we really is one of the core features and hallmarks of home and community-based services across the lifespan. And similarly, most people who receive services can contact their case manager or care coordinator when they need to. We certainly want to acknowledge that turnover in this area across the home and community-based services system is a very significant factor, and is also something to point out. But in general, some of these statistics show that people can access someone when they need to ask questions about their services and supports. Okay, so now I'll shift into just a little bit more information about the overall structure of long-term services and supports and home and community-based services. So I should say from a terminology perspective, when we think about long-term services and supports, that's a broader term than home and community-based services. LTSS, or long-term services and supports, can include things like nursing facility care and other services, whereas home and community-based services are those delivered just in the community, not in institutional settings like nursing homes and nursing homes or hospitals. So just a point of clarification there if you're seeing those two phrases and wondering how they're different from each other. So how do we make this all happen? So the image you have on the screen here is just a very simple representation of the way that DHS and the Minnesota Board on Aging work together to create a service system that meets a wide variety of needs, from low-intensity needs all the way up to those higher, more intensive residential services that some people need and want to access. So in general, when we talk about DHS, we're really talking about the Medicaid waiver programs, so EW, the alternative care program, personal care assistance, home health, things like that. And then coming around alongside or incorporated within are services that are delivered and paid for under the Older Americans Act and distributed to the area agencies on aging, and Carrie will go into more detail about that. Wanted to kind of point out as well that the two oval circles or ovals you see at the bottom of your screen, the Senior Linkage Line and the Office of Ombudsman for Long-Term Care, are both programs of the Minnesota Board on Aging. So in that capacity, they report to Carrie as the executive director. And I'll just say I'm proud to call myself an alumni of the long-term care ombudsman program. So very familiar, great services and supports, and also see a lot of the benefit to having those programs housed administratively in the Department of Human Services so that we can work really closely to, again, make a service system that really makes sense and coordinates together so that seniors and older adults and their family can access those services as they need to, when they need to, along that continuum of their aging journey. And I think the other thing I'll say just about the kind of the coordination and collaboration between the Board on Aging and the Department of Human Services is it really also allows us to think about our system in terms of not just the Medicaid program. So as many of you might be aware, to qualify for Medicaid is a poverty-based program, and so people have to spend down income and assets when they're over 65 in order to access those Medicaid services and supports like EW or alternative care, which has a little bit more generous of income and asset limits and restrictions. But we also want to make sure that we're not solely relying on Medicaid as the backbone of our system for supporting seniors, that we want to make sure that people are able to access services early and often on that lighter and less intensity scale, and those tend to be more the services provided under the Board on Aging or the Older Americans Act, but not always. People may be accessing other services and supports, sometimes through Medicare or other plans that help them stay in the community, get a little bit of help, and maybe delay the need for more intensive services and supports. So the ability to really leverage those Older American Act funded services helps us figure out different ways to finance long-term care in a way that maybe is not just solely reliant on Medicaid, because we understand too that it's very expensive to pay out of pocket for long-term care, and people who have been very responsible, saved money, been very fiscally responsible would spend down really fast. And so how can we prevent that or delay that or make it easier so people don't have to become impoverished to access the services and supports they need in their community? So I see a real benefit in the way that we are organized, because it helps us really think broadly on that continuum. And when we get to the point where we talk a little bit about what's next and what are some of our recommendations, Carrie and her team are doing some really exciting work regarding long-term care financing and what that might look like in the future. And so we are really excited to share that with you. Maybe we can touch on it today, and if it's of interest to this task force, we'd be happy to provide more information or come back, whatever makes sense on your end. Okay, so I am going to hand it off to Carrie to talk about the Board on Aging.
Thank you, Natasha. Can you all hear me?
Please state your name for the record and then proceed with your presentation.
Thank you, Madam Chair and members. My name is Carrie Benson. I am the Director of Aging and Adult Services Division at the Minnesota Department of Human Services. And in that role, I also serve as Executive Director of the Minnesota Board on Aging. Very happy to be here and join Assistant Commissioner Mers in this presentation. And just to add a few points on regarding this continuum, so to speak, of services for older adults. And then I'll transition into delving into more detail on some of these pieces. One of the things I like to highlight is that we call it a continuum. And we've kind of lined up these programs in a way where, the least intensive services, as Assistant Commissioner Mers was referring, least intensive services available through the Older Americans Act, with sliding fee scale, cost sharing availability, those providers also serving individuals who are able to pay privately. And then as you go along this continuum, then we have more and more intensive services available for individuals with decreasing incomes, potentially less, oftentimes less family support available as well, increasing need for services. And so in that way, we've got a continuum in Minnesota, as was mentioned earlier, that is ranked very high nationally, if not number one, then very, very close to number one nationally on an annual basis. And so we want to lift up the fact that there is a lot of really good resources available already for older adults and family, friends, and neighbors who are caregiving. Some really great resources to build on. Within this continuum then, and of course nobody really goes through this the system in a linear fashion, right? So it's a visual guide hopefully for our work together, but just noting that none of our lives, I think, take a very linear path. But as a part of this continuum then and how we get this work done, my roles are dual roles. I wear two hats. I oversee the home and community-based services programs on this continuum under the leadership of Assistant Commissioner Mers. And as I said in my introduction, with those two titles, I oversee both the Older Americans Act under the guidance and leadership of the Minnesota Board on Aging, which is a 25-member governor-appointed board that oversees the administration of those funds, and then within DHS, then the other home and community-based services programs. So what we were hoping would be helpful is we'll dive into a little bit more detail on each of these items within this continuum and hopefully just skim the surface enough to give you a sense of the scope and the breadth of the current resources available. And as Assistant Commissioner Mers has already pointed out, opportunities as we see them, as our partners are seeing them, for further improvements, further enhancements, and building on. So we're hoping this is helpful, still staying at a fairly high level. For the Older Americans Act services, you will remember hearing from Lori Vrolson, Director of the Central Minnesota Council on Aging, one of our regional area agencies on aging, about the aging network in Minnesota and the delivery of those services, the lighter end services. Maybe it's a call to the senior linkage line, maybe it's a home delivered meal, a ride to the doctor. And so you can see the number of units or people reached with those services. But I do have to point out that it could not be possible to deliver these services through the Older Americans Act funding and related funds without the really great work of approximately 100 contracted service providers in our network and many, many, many volunteers who are involved in the delivery of these services. I will note that these service providers are also billing other revenue streams for our home and community-based services programs. That's a strength we have in Minnesota, that we have very strong providers in place, long-standing, and are able to access the various funding streams as well as do private pay and sliding fee scales. And next, I will turn it back over to Assistant Commissioner Mers.
Thank you, Ms. Benson. So I'm going to talk a little bit about the Medicaid services or the quasi-Medicaid services that are available that the department administers. So again, sort of separating this from the Older Americans Act services just for purposes of helping us all get clear on what's available and what the payer sources are. So we have three main services in the department that support seniors with health-related and social support needs. The first is essential community supports, and this is, again, maybe more of a lighter touch, lighter end service. It's a pretty small program, and so it doesn't reach a ton of people, but it was designed to kind of meet those needs of people that aren't meeting a level of care requirement, and I'll explain that in a minute. But it provides up to sort of those lighter end supportive services, coordination, and things like that. So one of the things that is kind of foundational to the way the federal government has set up our Medicaid waivers programs, or the services, the Medicaid funding that pays for services in assisted living or in people's homes, is the person that's applying for that service has to meet what we call level of care. And what that means is that they have to, via an assessment, it has to be determined that if they didn't receive services and support in the community, they would otherwise need a nursing home level of care. So meeting that threshold is what allows people to then qualify for Medicaid services like elderly waiver. And so essential community supports is designed to be provided for people for whom they don't have needs that significant or intensive. So that's just a brief explanation. And alternative care is not technically a waiver program, but it is a program that we administer kind of side by side with elderly waiver that has more generous income and asset requirements. And by more generous, I mean people can keep more of their income and assets and still qualify for the program. Also a small program that we'd like to see bigger take up on. But it provides many of the same services as elderly waiver, but maybe doesn't require a spend down of income and assets quite as extreme as elderly waiver. Elderly waiver is the program under our waiver for people 65 and older. I will say that for people that meet a level of care, a nursing facility or higher level of care before they turn 65, they can access a disability waiver, whether that's CADI, CAC, brain injury, or DD if they happen to qualify for that. So for people that are on waivers and they turn 65, they can stay on the disability waivers. They don't automatically have to transition to EW. But if you come into the waiver program 65 or older, EW is the service that's available to you. And so you have to meet the requirements of medical assistance, both for income and assets, and then also meet that nursing facility level of care requirement. And EW provides a lot of different types of medical, health-related, and social services to help people stay in their homes and communities. One of the services I mentioned before, customized living, is what pays for services in an assisted living setting. But there's also a lot of services under EW that can be delivered in the home, whether that's assistance with activities of daily living, meal prep, chore services, things like that. So here's just a little bit of more information about that. I think I've kind of talked through some of those requirements, but just wanted to give you kind of a foundational groundwork of how does the Medicaid program support seniors in Minnesota, and these are kind of the three main pillars, and we'll talk more about the additional services funded under the Older Americans Act that kind of fill in and widen out that picture for people.
And I will jump in here and add a few points on these last couple slides related to the means-tested programs. Hopefully you all were able to pick up a copy of or access the program comparison chart. has a lot more detail, still skimming the surface of these 3 programs, but hopefully that's a helpful resource as we kind of build out the resources available to the task force members and those interested in the public here as well. You know, I will just I want to emphasize a couple points that Assistant Commissioner Mers made about these programs and that there is low uptake. You know, the Essential Community Supports serves annually not quite 200 people. It's a great program, good services just in time, you know, and earlier on in the need for services, but there's low uptake on that. That's an opportunity for Minnesota. Also, the fact that we have 3 programs, and these have built up over time, thankfully, given the leadership of the legislature over the years. We have, again, as I was mentioning earlier, a very robust system of services for older adults, but these built up over time, right? And there's been tweaks to them over the years, and it does not make it easy for older adults to access them. And it makes it confusing, frankly, for any of us trying to access services when we need them, or as a family member trying to help a loved one access these services. So, as Assistant Commissioner Mers mentioned earlier, we have some really exciting work underway. We've contracted for work underway to really step back and really think through what could be the next phase of redesign for these programs, for how they coordinate with the Older Americans Act, how they coordinate with private funding options, and really take our system to that next level. So you can tell I'm really excited about that work and excited to be able to, you know, share that with you all and connect you with the experts in the field that have really been leading the way for us on that. So I just wanted to highlight a few of those items as we move on to our next section of our presentation. This is our second strategic priority that really guides the work that we do across our home and community-based services programs for older adults. And it is our efforts to make it easier to access services when you need them. Excuse me. So through the Older Americans Act, we are able to make available for older adults, family, friends, and neighbors who are caregiving, as well as service providers, other members of the community, the Senior Linkage Line, a toll-free 1-800 number you can call 8 to 4:30, Monday through Friday. You'll note that's an area of opportunity as well, because that's not typically, especially family caregivers, the time that you have available to give us a call. But we're available to provide information and assistance regarding accessing services in the community, as well as counseling regarding Medicare, which can be an incredibly complicated endeavor to understand. And then you'll see another top area of calling is housing. What are the housing options in your community? Do you need to move in order to receive services? What are those options? Even if you're just wanting to downsize, right, and kind of navigate that system as well. So you'll see the number, excuse me, of individuals reached annually through the Senior Linkage Line. We like to call this the front door to our system, and it really is a very big door to the system, right? Really, any caller, anybody can access the assistance through the Senior Linkage Line. And I want to note that the Minnesota Board on Aging delivers that in partnership with our regional area agencies on aging. In some more detail, the services available through the Senior Linkage Line you can kind of put into 2 categories. One is information and assistance, and like I said, that's access to services in your community, as well as assistance in understanding and making good decisions about your Medicare coverage. The other category is what I like to refer to generally as transition assistance. So you'll see a number of different services. We call it often a suite of services that the Senior Linkage Line provides. And a lot of this is around transitions transition from hospital to home, from Medicare home health ending to other services in your home, from nursing home to home, really a lot of the transitions that we all tend to experience, right, as we grow older or we are helping a loved one navigate. And again, this slide shows some of those as well as then a little bit more detail on our information and assistance services that we provide. You'll see on the bottom of this slide the link to minnesotahelp.info. That is a website that we co-host together with the Disability Hub to provide information about services available to older adults and people with disabilities in the community. It also houses a wealth of other information on community resources, so we want to make sure you all are aware of that. It is the same database that the Senior Linkage Line call specialists use, so we put a lot of work into that and making that available. It will link up to the Assisted Living Report Card, which is in process and to be launched later this year. Most people who call the linkage line are satisfied with the help they receive, similar to the National Core Indicators survey. For our means-tested programs, we survey the people we serve throughout our other programs as well. And so wanting to share some of these data points, and we use this to really guide our efforts to assure overall high quality in the services that we provide to the people who call, and of course also to the people we serve in person. A lot of that transition assistance, I forgot to mention, is offered in person as needed. We go to people's homes or the nursing home to offer that assistance. And now I'll hand it back over to Assistant Commissioner Mers.
Thank you, Ms. Benson. So I want to talk a little bit about the Min Choices Assessment and what it does and kind of where we are, because we're at an exciting phase in that project. So previously, I mentioned that in order to access elderly waiver and other services that you need, or the services available under elderly waiver, that a person has to meet a nursing facility level of care, or they have to say with absent these home and community-based services, the person would otherwise need to be in a nursing home to have their needs met. So the Min Choices Assessment is a comprehensive online assessment to our cloud-based assessment tool that's utilized by our tribes, counties, and managed care entities or lead agencies to assess people to determine if they meet a level of care requirement and access a suite of different services that cross the aging and the disability service spectrum. So Min Choices assesses for the disability waivers that I mentioned earlier for people that are 65 and under coming into Medicaid, personal care assistance program, which is available across populations, as well as elderly waiver and alternative care. So it doesn't assess or determine eligibility for Older Americans Act services. That happens through the area agencies on aging, and Carrie can talk a little bit more about that. But it's just important to realize that we do have this assessment tool that we've been working really hard to create a really person-centered assessment that occurs in a person's home, and a trained assessor that comes out and utilizes the tool to have a conversation with the person, but also get answers to the questions that determine eligibility through that level of care assessment, and then creates a support plan or a draft support plan that can be sort of the basis and foundation for figuring out exactly what services and support a person wants after they've met that eligibility threshold. So we talk about in the waiver programs, including EW, that there is kind of a menu of services available. And so the Min Choices Assessment is going to assess for that level of care eligibility, and then also within that make a finding that maybe the person being assessed, for example, needs assistance with bathing and with transferring, let's say. And so it's going to then make maybe some recommendations about services and supports that would meet those needs. But it's really important to know that once you've met that eligibility criteria, that level of care, it is a conversation with the assessor, and then later with your case manager or care coordinator about exactly which services are needed and wanted. So For example, sometimes a person can have a dependency in maybe they need help bathing, but they have someone in their life that they already trust to help them with bathing, and they don't need that service. So they might pick a different service that is needed from that menu. So the point here is that once you meet that level of care requirement and qualify for medical assistance, people that are using services and the people that support them have a lot of choice and autonomy in working with their case manager or their county representative or their assessor to determine the types of services they want and what they don't want. And then for the services they do want, how those services are going to be delivered on what kind of timelines and timeframes. And certainly these choices are limited by things like workforce shortages. So I don't want to pretend that it's super easy or always works out exactly how people want it to, but I do experience when I talk to people, people think they have less control than they actually do in the home and community-based services programs, that those programs really are designed to be flexible, to have sort of evolving or changing service plans and service needs, because the programs themselves recognize that we are all, as humans, changing. Our needs and our support needs changes, and HCBS services are designed to provide that flexibility for that. So the Min Choices assessment, as I said before, will be a conversation delivered in someone's home. There are some remote options in certain circumstances, but really the preferred or the best practice is to have that assessor come out, make an appointment that works for people, and then really conduct that assessment online using a laptop or whatnot, and then that becomes the basis for the support plan. And that's where that really informed choice conversation comes in between the person and if they want to have a caregiver or someone with them to help, to really have a conversation about what's needed, how's it going to be delivered, trying to really emphasize those person-centered principles of people that use services don't give up their autonomy and their right to control their life. These are supports coming in, and they have the right to design those supports in a way that makes sense, so long as they meet really basic health and safety needs. Those are federal requirements that it has to be safe. So we launched the original Min Choices tool in, I think, 2014. And we are been working on a revised application. So basically using a different tool. So moving it off of our Minute IT systems and onto a third-party vendor system, which is going to, over time, be the future for our IT systems and state government. And it will take us a while to get there, but we're really excited about that new strategic direction with service delivery transformation. Min Choices is a good example of really working towards that. So we have launched our revised Min Choices tool and application and are currently working directly with our lead agencies, counties, tribes, and managed care entities to fully transition them from utilizing the old system and into the new system. And we're trying to do that in partnership with them in a very thoughtful and deliberative way, because these assessments are comprehensive. The Min Choices assessment assesses across a wide variety of programs, and so there are a lot of questions to be answered. But I really like to remind people before Min Choices, what we had were paper-based assessments for every particular service and program. So you would have to get a PCA assessment, then you might have to get an assessment for elderly waiver, and if you were under 65, you would have to try to figure out which disability waiver assessment to ask for. And so it really put a lot of burden on people to try to understand the system, to know the right words to say in order to get the right assessment. And so Min Choices really takes at least some of that burden off and really says, tell us what you need, let's have a conversation about your needs and supports, and determines that eligibility, and then provides that springboard for a support planning conversation with the folks, with the person and the people that they determine or decide are going to be involved in that planning process. And often those are caregivers, for sure. So you've got just a visual up there of the implementation plan for Min Choices, and we are trying to be as flexible as we can with counties and lead agencies as they work to balance workloads with Medicaid renewals and transition to a new system, and as we're working in an agile way to continue to make improvements to the tool itself. So there's a lot of kind of different factors that influence how this will go, but just wanted to share where we are and feeling really positive about it, and have gotten good feedback, both positive and things we need to work on from our counties and lead agencies in terms of the tool itself and training and needs. But really just thrilled with all the work that everyone has put in to make this launch successful. And all right, with that, I am turning it back over to Ms. Benson.
Thank you, Assistant Commissioner Mers. I will take your cue that you provided to me, thank you, earlier about the criteria for Older Americans Act services, just to briefly touch on the fact that there are not any means-tested criteria for Older Americans Act services. So the Federal Older Americans Act provides funding to each of the states and territories to deliver a set of services to older adults and family, friends, and neighbors caregiving, age 60 and older. And so that is a very broad basis for eligibility for the services. However, then the Older Americans Act provides criteria, targeting criteria, to serve older adults in most social and economic need, with particular preference being given to older adults who are experiencing disparities in service and access to services, including older adults of color, Native elders, and older adults living in rural areas and with low incomes. So within the Older Americans Act, again, that's a broad scope to serve a very large population, targeting those services in and with that kind of that light touch of the services. I will note, in terms of access to services and the senior linkage line in comparison to the MnChoices application, I just want to note for you all too that as people come to the front door, senior linkage line, and are sharing their situation and may need services, may qualify for services in the means-tested programs, then that handoff is made to the lead agency, whether that's a county, tribe, or managed care organization. So we do have those referral patterns in place, or processes, I should say, as well as with our other healthcare and long-term services and supports partners in the system. And so wanted to note that as well. Now I'll move on to our third strategic priority, which is to support family, friends, and neighbors who are caregiving. I am taking this one because our work on supporting family, friends, and neighbors caregiving really is, in particular, supporting older adults to age in community, really is based on the foundation of the Older Americans Act and the National Family Caregiver Support Program that was passed a number of years ago. So as with our home and community-based services for older adults, the National Family Caregiver Support Program provides the framework that we use then to guide all of our funding streams, public funding streams, to support older adults and support their family, friends, and neighbors who are caregiving for them to get the help that they need, get a break, if they need respite, training, counseling. And so that is how we are able to kind of organize and coordinate our overall system of services and supports, is by really using the Older Americans Act as that guiding framework across our system. As it notes here, most home and community-based services are delivered by family, friends, and neighbors who are caregiving. I mean, it's the vast, vast majority. We all know probably the statistics here that we have on the slide. This is a very critical workforce strategy, right? We've got a workforce shortage, Assistant Commissioner Mers noted, we are all very well aware of. The biggest part of our workforce is each of us helping out our loved ones, right? Or our friends or our neighbors in help around the house, help with a little bit of personal care or a lot of personal care, help in supporting somebody who is experiencing Alzheimer's disease or related dementia. So this is an area where we are really seeking to do more, and more with public and private partners, and more in building on the programs that we currently have available to really support family caregivers. I will note also, you'll hear from the health department about their work in this area too, and it's one of several areas where we are partnering to support either older adults or family, friends, and neighbors caregiving. So this slide shows some of the data points we have on our Older Americans Act funded services. And on average, that a caregiver who is served through our programs receives per year about 51 hours of respite or 6 hours of counseling. Again, this is a menu of services as well and provided as needed to family, friends, and neighbors caregiving who are most in need of that support. Again, we have a survey that we conduct of caregivers that we serve to see, if they find our services helpful. They report that they have helped them cope better with their role as a caregiver, has helped them care longer, has increased their skills and ability to provide the care that they do to a loved one. And so these are important data points that we really pay attention to and use to inform our work. However, it's a little bit, I won't say a little bit, it is limited because it is a general survey that at this time we don't have additional resources to really delve into any racial or ethnic differences as well as differences by geographic area. I also wanted to highlight two programs that the Minnesota Board on Aging administers, and these were authorized through the state legislature because of the recognition of the aging network in Minnesota and the experience and success that the Minnesota Board on Aging has with its area agency on aging partners and service provider partners to reach family caregivers. And so to really tap that infrastructure and add to those resources available to help caregivers, in particular target populations. So the Minnesota Board on Aging administers the Dementia Grants Program, annually receiving $750,000 to award out through a competitive RFP process to local organizations. And they work on increasing awareness of Alzheimer's disease and related dementias, promoting early diagnosis and connecting caregivers to resources. And that is an ongoing program through which we receive that funding and do that, the grant awarding process. And then in addition to that, the Minnesota Board on Aging received a one-time $5 million appropriation for caregiver respite in honor of Senator Tomassoni, who suffered from ALS and passed away fairly recently as a result. And so this, we were very proud to receive one-time funding available to us through 2026 to provide for respite for individuals who are providing critical support to their loved ones with ALS. And so part of the funding provides funding to each area agency on aging for training on ALS, for caregiver consultants to be trained on how to best support caregivers and the person with ALS. And then in addition, the vast majority of those funds will be provided for respite services. And next, I will highlight very briefly our strategic direction on promoting healthy aging across the lifespan. I say briefly because you will be hearing from the health department, and much of the work that they will be highlighting, we do in close partnership. And I will say we have found such great opportunities to partner with our sister agency in the area of nutrition, healthy eating, supporting family, friends, and neighbors caregiving, falls prevention, chronic disease self-management, pain self-management, just a number of areas, as well as brain health. And so we look forward to you hearing their presentation as well. I will give a shout out particularly to the Wisdom Steps program, which was developed by Native American elders for Native American elders. That program reaches about 400 Native elders annually, and it is now a separate nonprofit, and the Minnesota Board on Aging was very proud to be a part of supporting that in its development efforts early on. So now I'll turn it back over to Assistant Commissioner Mers.
Thank you very much. So moving on now to our next strategic direction or strategic area, strengthening older adult rights, autonomy, and protection, which is very close to my heart. As I mentioned before, I spent a good part of my career with the Office of Ombudsman for Long-Term Care in various positions. So taking this one because I'm pretty familiar with it. Next slide.
Would you like to do the ombudsman first?
Oh, actually, I'm going to leave the ombudsman to Carrie, and I'm going to talk about the Minnesota Adult Abuse Reporting Center. I get really excited talking about where I used to work. Next slide, please. So one of the core foundational services here for protecting and strengthening protections for vulnerable adults, including older Americans or older Minnesotans, is the Minnesota Adult Abuse Reporting Center. So this is a 24/7 center where anyone can make a report of suspected abuse, neglect, or maltreatment, and that includes maltreatment or includes financial exploitation, just to make sure to throw that in. It's also, a pretty broad definition as defined under our Vulnerable Adult Act here in Minnesota. So this is both the place people can report, and it's also the place where people that hold licenses that make them mandated reporters have to report. They're mandated to because of the nature of their work, whether they're a nurse or a social worker or a doctor, and there's a longer list of those. So this is the centralized web form or base that calls come in or referrals come in to the Minnesota Adult Abuse Reporting Center. At that point, the person answering the phone call or managing the inquiry will determine if there's immediate emergency services that are needed, and if they are, we'll dispatch those appropriately. But for the substantive follow-up and the referral, they'll make the referral to the appropriate lead investigative agency. So it depends where the alleged abuse, neglect, and maltreatment is occurring. If it's, for example, occurring in someone's home and the allegation is against a neighbor or a caregiver, it's likely to be triaged to the county Adult Protective Services, which will then determine, take the information and determine if they should open an investigation or not. If it's, for example, a complaint about quality of care or rights or something in an assisted living, then the health department would be the lead investigative agency. So the purpose of the MARC call center is both to take reports, triage for emergency services, but then also to determine which agency it should go to for follow-up and reporting. So wanted to share out some data on the MARC system here. So you can see these are reports by age of adult in 2022. So you can see a lot of reports coming in for ages 40 to 64, followed by the next most voluminous is ages 65 to 74. So I had sort of mentioned this in my earlier comments, but this is sort of a flow chart of how the MARC system works. So I think I won't go into that. I know we're getting short on time, but this is just a visual representation of how the workflow moves to make sure that reports are investigated. And then similarly here, you can see the total reports by lead investigative agency, or again, that's whichever agency has the legal responsibility to provide the investigation and potentially, make a finding that the abuse, neglect, or exploitation did or did not occur. So I want to spend a little bit of time here talking about the vision. For adults that may be experiencing abuse, neglect, or maltreatment. And one of the most important things here is that we know in terms of providing real protective services for people to prevent that exploitation, abuse, neglect in the future, or to remedy what's happened, that we really do need to take a culturally specific and culturally appropriate approach to providing services and supports. And understand that things change and flex over time. Adults need support sometimes, and we also have to make sure that we have to respect the rights and autonomy of the vulnerable adult in that process. So we don't want a system where the lead investigative agency comes in and takes over and decides what's going to happen and what's important. We want, of course, for that investigative agency to stop the abuse, neglect, or the exploitation, or to change conditions so that it doesn't occur. But it's really important that we are balancing and valuing the choices, preferences, and autonomy of the person, of the older adult in this particular context, and really focus on outcomes, focused on keeping people safe and giving them as much choice and autonomy. When the system, in our past experience, when the system comes in and makes all the choices for someone, they are less healthy and safe over time because they lose that sense of control and autonomy. So we have to be really careful about when the system intervenes and when the system provides support and how we balance those things. And those balancing, what is important to a person, their rights, their choices, their autonomy, relationships, their community, with their health and safety is really a core principle and function of person-centered thinking, which is a requirement across our home and community-based services programs, both for seniors and people with disabilities and anyone that needs some type of a long-term care service and support. We're always trying to balance those two things appropriately with any type of system intervention, whether it's in the context of a vulnerable adult investigation or it's simply a family that needs support and services. Is really trying to create and train the people that are going to interface with them about the value and the need to balance important to and important for to get to those person-centered outcomes, and really emphasizing that choice, control, and autonomy has a direct connection or a hook to people being safe. If people feel like they have control and they do have positive control over their life, they're more likely to be safe in the long run. And so that's really one of the core principles that underlies the way we deliver services, but it is of particular importance when we're talking about the Vulnerable Adult Act and potentially having to come in and do something or a system intervention that is coming from a mandated report or something like that. So just quickly, we'll talk about the duties of the lead investigative agencies. So immediately respond to the report. There may be emergency services involved if that happened at the MARC level, but if not, there are timelines for the lead agency to respond to the report, to use their established guidelines for finding which reports will be prioritized for investigation, notify within 5 days the reporter of the initial disposition or the initial response, conduct the required investigation, and make a determination about those allegations within 60 days, and then engage in all the required notifications if the investigation is closing. All right, now we really are going to move on to the Ombudsman for Long-Term Care, and I'll hand it back to Carrie Benson.
Thank you, Natasha. Just one note on the adult protection area, and I know we're getting really short on time, but I do want to really extend my heartfelt gratitude and just sincere thanks to our county adult protection partners in the field doing just such incredibly important work that they do. And I'm proud to have the Adult Protective Services program within the division that I oversee, and it performs such an incredibly important function in our system for adults, vulnerable adults age 18 and older, when a potentially bad situation, bad occurrence happens. And so it's an incredibly important service, and one that we are working very closely with our county partners, tribal partners, to re-envision. And legislators might be aware of efforts which we have described as a Vulnerable Adult Act redesign, and would love to be able to come back and tell you more about that and what we are coming to together to identify as our shared mission in terms of implementing this vision, our shared goals and objectives in addressing disparities in outcomes for adult protective services, and what we see as kind of the future of protecting the rights and safety of all vulnerable adults. I will transition then to the Office of Ombudsman for Long-Term Care, and Assistant Commissioner Mers handed this over to me since it is one of the two direct service programs of the Minnesota Board on Aging, the other being the Senior Linkage Line. The Office of Ombudsman for Long-Term Care has a very unique role in our system of services for older adults and people with disabilities who receive long-term care or long-term services and supports. Both are synonymous. The care is headed by Cheryl Hennon, the State Ombudsman for Long-Term Care. And as it is outlined in the Federal Older Americans Act and authorizing regulations, State Ombudsman Hennon operates with autonomy and independence in her role as Ombudsman for Long-Term Care. And that is across all of the home and community-based services and nursing home services in the state. She and her team of central office staff and regional ombudsmen serve as advocates with and for people who receive long-term care. And she has been very grateful for the increased investment that she has received from the legislature over the past few years to really grow the capacity of the Ombudsman program to serve individuals who are receiving long-term care and advocating for their rights and addressing complaints that they have. Currently, the Ombudsman focuses most of their services on residents, supporting residents in nursing facilities, some in assisted living facilities, but there's much more to do. And so you will continue to hear from Ombudsman Hennon as she moves forward in really continuing to kind of grow and evolve the office and her work. So like I said, they provide that individual level assistance, and with that information, with that data, they also then advocate for systemic level change across provider settings and across the system overall. So Ombudsman Hennon is called upon and required to address concerns that she identifies through her work with the Department of Human Services, with the Minnesota Board on Aging, with the Minnesota Department of Health, and other entities, Department of Veterans Affairs, and so on. And so we have established policies and procedures in place in order to allow for her autonomy and independence and being able to fulfill her role and fulfill compliance with those federal regulations. Here are some data points regarding complaint types. So this is the individual level complaint work that Cheryl and her team do each and every day, working alongside individuals who receive long-term services and supports. And again, a little bit more about the office itself, now with 25 regional ombudsmen, and those are all of us doing a happy dance, that there is that much capacity now, and hopefully will be growing into the future. They perform incredibly important, diligent work in working alongside individuals one-on-one, and you'll see the impact noted here. And what's next? And I will turn it over to Assistant Commissioner Mers.
Thank you, Ms. Benson. So wanted to do a little bit of a time check here. I think what I can do is walk quickly through some of the things that we are anticipating and excited about, and then can check in, and if you want me to go into more detail on a particular thing, either now we can do that, or we also would be very happy to come back in any capacity and do a deeper dive on some of these really important issues. So some of the things we're focused on in terms of our systems work is really working to address disparities in access to service outcomes, particularly for our seniors of color and Native American elders, really trying to understand from a disaggregated data level where those disparities are and what types of system interventions would be most effective to start addressing and reducing those disparities. Increased support for vulnerable adults experiencing self-neglect. So that is one category of reports into the MARC system, is when an elder or a senior isn't taking care of themselves, or there's concerns about their safety in the community. That is a large percentage of some of the calls that MARC receives. So this is a significant issue, and really, again, in that frame of respecting rights and autonomy while balancing with safety, we have to, I think, develop different and additional system interventions to support people that may be experiencing self-neglect or need some type of support that they haven't yet accessed. And then, as Carrie mentioned before, the value of unpaid caregiving in Minnesota and across the nation is absolutely astounding. I don't know what our system would do if we suddenly did not have the family caregivers and those informal supports. So we're really always thinking about how do we take that support to the next level. And we have some very exciting studies and findings and recommendations that we'll be excited to share in more detail if that's of interest to the task force. Some of the other big things we're focused on is streamlining the existing public system. So we talked a little bit about, some of the low take-up in the Essential Community Supports Program and less take-up than we would like in the alternative care. And how can we really think about how to streamline and align those programs to make them easier to understand and easier for people to access? We are lucky to have a very robust set of long-term services and supports in Minnesota and solid financing and support from the legislature to develop those programs, but it is a complex system because it's been built up over time with different and new programs. And so some of our work now is to try to figure out how to simplify and align those things. Particularly when we're talking about support for family caregivers, but also just across the LTSS system. We'd really like to, leveraging those Older Adult Act services and services like the Senior Linkage Line, reach people earlier in their need for services and maybe be able to more flexibly offer those lighter touch services. Those, when put into the, implemented, really can prevent the need for much more acute, intensive, high-intensity services down the road. Sometimes prevent, but sometimes delay, and either one is a good outcome because people are living in their homes and communities, giving services and supports where they need them. When I was with the Ombudsman's office, one of the things I experienced or observed was a lot of people were hesitant to have a little bit of help come in because they thought it meant, the next step was the nursing home, or they thought it meant something else, and so they would wait sort of too long to get any type of service and support, and by the time they accessed it, there was a need for maybe more intensive services, 24/7 supervision or things like that. If we can really help people understand that these services are there, particularly Older Americans Act services, to support community life, we think that will go a long way in allowing seniors to, continue to contribute to their communities and prevent the need for people to have to leave their homes to receive services. So within that, on the financing side, we've done some very exciting work through the Own Your Future program that now lives under Ms. Benson's supervision, and thinking about different ways that we can combine public and private financing to address that, how can we help people access services they can afford without having to spend down fully to Medicaid or to that poverty level. So really excited about that and can certainly share more about that in the future. And finally, wanted to quickly make mention of our Age-Friendly Minnesota Council. And this is a really important area of work as well that has some administrative support from the Department of Human Services. And we really look at Age-Friendly as a really important addition to our whole service support infrastructure. We really recognize that people have needs. Like all humans, seniors have needs that aren't just in home and community-based services programs. They might, they need housing, they need transportation, they might be a veteran that needs those supports. They might need income support, or their family caregiver might need help. And so Age-Friendly is a place where state agencies come together to really talk about how can they structure their policies, procedures, and agency priorities to support our aging population, apart from the long-term care service and support system. But of course, we are there also as partners at the Department of Human Services to help coordinate and align and make sure that whatever's happening at Age-Friendly makes sense in the context of Older Americans Act funding and the Medicaid waiver system. So really trying to bring all those things together. And with that, that is what we have to share for you today, and I thank you for your patience and attention as we share. We're always really excited to share all the great work and identify ways that we can partner with legislatures, with citizens, with advocates to continue to improve our LTSS and home and community-based services system in Minnesota.
Thank you very much, Assistant Commissioner and Executive Director and Director. You covered a lot of ground, and we're grateful for it. Are there questions from task force members? Dr. Gogler.
Yes, thank you so much. Again, always wonderful to hear about the comprehensive and great work that's coming out of both the Minnesota Board on Aging and DHS too. You had touched on 2 points, and I would hope we as a task force, when we consider what our mission and charge is, think about it really carefully, and maybe it would require coming back and reflecting on this. One is, you made the point very clearly about how really the core of the long-term care system in Minnesota and U.S. is this very extensive network of unpaid care providers, families, most often. And one thing you didn't note, and I think would be important to note, is right now, if you really look at long-term care policy in many ways, it assumes this ongoing reliance of families. This idea that, the goal is to delay nursing home admission in large part because of the costs it often poses to the public taxpayer. But if one looks at estimates in the upcoming decades, we can't rely on families because there won't be as many for a number of sociodemographic trends. And I think when we think of our charge as a task force, it's wonderful to hear about all the great services and supports. I quite frankly am a lot more interested really in your last slide. How are we positioning for the future? And I think as a task force, that is what we need to be focused on. You had talked about long-term care refinancing, for example, and again, I can provide this to the task force. I don't know if you remember, Carl, you might have been there. This was in January 2020. The University of Minnesota put on a forum of national experts that actually provided examples of these refinancing models. One state that is far ahead of us in this regard is the state of Washington. They have put together the Long-Term Care Trust Act, I think it's called. I forget the exact. I'm also drowning in acronyms myself, but I mean, and I think we as a task force should become aware of these different refinancing options to determine what's palatable for our state. That's not the only one. There's 3 or 4 others, and we put together a white paper that we can share. Now, as we know, the subsequent months led to a big change in things, but I think we should revisit that work and when we consider what we're doing as a task force, so. Thank you again.
Thank you, Dr. Gogler. Do either of you care to comment on Dr. Gogler's comments?
Madam Chair, just to say, I think those are really important points, Dr. Gogler, and we would be very happy to share the work we've been doing on long-term care financing and partner to figure out what are our most viable policy paths going forward.
And I'll just add to that to say that it's an incredibly important avenue to not just explore it, but to take action on in terms of the financing, but also how we rethink what it means to provide support. To your point about, a declining workforce means also declining, paid and unpaid, right? And so what does it look like for us all to come together and support each other as we grow older as a society? And so I think it's both and really, really exciting developments that we could share.
Thank you. Thank you. I think Ms. Foley, you were up next.
Yes. Yes, I would like to thank you for your presentation. Thank you for your presentation today. I have a couple questions. In your early slides, you said residents in rural areas are 2 times more likely to be in their 80s than in the urban areas, and also that 1 in 5 older adults receive services. Do you know what percentage of the adults in the rural areas receive services versus the metro area? Mm-hmm. Is it the equally portioned 20%, 20%, or I was just kind of wondering if people are more apt to receive services in the metro area versus the rural area?
Director Benson, you look like you're ready.
Madam Chair and members, thank you for that question. You can tell I love talking about this. So we do have some data on that. I would like to offer to follow up with more details on that. There are some differences, rural versus urban, somewhat due to availability of services, but we also see some common trends across the rural and urban. And so I think what we can do is add to some of the data that Susan Brower, the demographer, shared with you all at the first meeting, and I think followed up with as well. And then we could add to that our county level data. We just got updated 2022 data that we could share.
That would be great. Thank you.
One more
Sure.
question.
Go ahead, Ms. Foley.
The senior linkage line, you say it's the front door to the system. How is it promoted? Where'd someone find it if you don't have like a computer, or, some of the older adults don't use computers. So how is it promoted so they can find the information to even begin the system?
Director Benson.
Madam Chair and members, that's a great question. And it's something we continue to work on, right? So in one of the slides, we had a number of individuals that we reached through events, and those are in-person outreach events our area agencies on aging work with local partners, local organizations to do outreach events, whether it be at health fairs or other locations. We do outreach through all of our Older Americans Act funded services, particularly the dining sites. Our senior nutrition program staff are incredibly helpful in getting the word out. But we also use some print media, some TV media, different outreach, kind of all the different vehicles or venues for that. But I will say it's a challenge. It's a challenge to raise awareness of a phone number that people don't necessarily want to call until it's almost too late, right? So that's the struggle I think we've always had in the long-term services and support system is, and for any of us as a society, right? How do we grab people's attention to start planning for and thinking about their future needs, potential future needs, right? If they are blessed with being able to, live long enough and need some help, and what does that look like, right? And so, and how do you prepare for that financially and otherwise? So that's what we struggle with the linkage line as well. So I really appreciate your question.
Thank you. Ms. Foley Moore?
And then I had one more, sorry.
Sure.
You talked about the min-choice assessment. Is that available to anyone to just ask for an assessment? Because I've had several of them now, and they're quite comprehensive. And, you talk about the shortages of case managers and case workers. I've had 3 and 5 years now. So with the turnover, so if if anybody can ask for one, how many are they doing? What's?
Assistant Commissioner Mers?
Madam Chair, members, yes, thank you for that question. Also a really important issue to highlight. So the min-choices assessment is available free of charge, and they're conducted by the lead agency in which the person is, the county often, but could be the tribal nation or the MCO in which the person is physically located. But you're absolutely right, Ms. Foley, that there are, counties experience and lead agencies experience their own workforce shortages, and counties have shared with us struggles to stay timely within conducting initial assessments or conducting reassessments. And so it is an issue that we're working, with lead agencies closely on, because you're absolutely right. They are comprehensive assessments. They take time. One of the goals of the min-choices revision process was to create, or is to create, maintain, and improve a tool that that's easier, we can be more agile in changing kind of the core functionality to make it more efficient, so that maybe they can, over time be more efficient assessments. And, we continue to work with our county partners and assessors on whether we're achieving that goal or not. Assessments, as you may know, are complicated, right? They are having individual people talk about some of their really personal and intimate needs, and you want to have a conversation that doesn't feel like an interrogation. You also want to assess across a lot of services and supports. So it's the sort of situation where I think we want to be as efficient as possible with the tool to try to maximize those workforce characteristics. We have brought forward proposals last session and have another one this session to make it easier to qualify to be a min-choices assessor, so that hopefully we can bring more assessors into the workforce to be able to conduct those assessments. And we've also created some flexibilities for remote reassessments in certain circumstances post-pandemic. So those are some of the strategies we've utilized to address that issue, but it is absolutely a very real issue that we need to continue to work on and sort of see how the revised min-choices hopefully will help and support us with that once we get over sort of the initial getting used to the tool and learning how to use it most efficiently at the lead agency level.
Thank you. Representative Zalesnikar, do you have a question?
Thank you, Madam Chair, and thank you for the presentation. My question was, I've been an unpaid family caregiver like many in the room. Does Minnesota right now have a program for paying families to provide care to Minnesotans? And I'm wondering what that dollar amount is, and when the program started, and who we're serving, because I know from the statistics that 23% of our population is over 60, but I'm wondering how many people are being cared for by paid family caregivers. But And if you could give us data for that, that's one of my questions. And then the other part was just the assessment process is great. I think the issue that's happened that's important for the public to understand is the terms we use are person-centered care, and we've been doing this for 30 years. And the thing that happened was called a pandemic. And so when we had care needs identified with no staff and facilities, then who's responsible for that? So right now, I think we have a revival of creating care settings that are with hope and optimism for the caregivers, because an example is if the care plan and the assessment from this process said you're to be toileted after every meal or every 2 hours, whatever time frame you want, but there is not the staff in the facility to do it. And it also says that you're not to leave the person when they're on the toilet. That means I can't go take care of anybody else in the room because I'm standing by my grandma Hazel for maybe 40 minutes, maybe 20 minutes, because I don't know how long it's going to take for each person, for person-centered care, to go to the bathroom. So that's one example. And so that level of stress goes to the caregiver, to the nurse, and to the aide. The care plan and the service agreement states X, but Y happened, which was the pandemic. And so I think it's really important that we realize we have regulations that were in place, and we surveyed our facilities as if we had no pandemic happening, and we had one. And so the survey findings, I don't think, are a fair reflection to the reality that the facilities had. And so I think that's something we have to work through to move forward in a healthy way. The last thing I'll just say as an observation is I think it's important that we look at the number of people that can't be discharged from our hospitals. Hennepin County, I get it every week. It's a trauma center, so if you're in a major car accident or you have a heart attack, anybody in this room, you could be going there and diverted because they can't take a bed. We have seniors that can't get placed, and some of them are very difficult to place in a traditional nursing home. I've had people placed in behavioral health units for 20 years, but there aren't a lot of beds available. And so I just toured a facility in Minneapolis, a nursing home, last week, and many of the beds were empty on the subacute rehab, and it's because people don't have staff. And I think we have to be innovative, and to the member's point here, of looking at the fiscal side, the planning side, how we're using space and buildings, and be innovative. So thank you for your presentation, and I look forward to finding solutions.
Assistant Commissioner Mers, I don't know if you wanted to maybe respond to the first part, or if that might be a follow-up offline.
Madam Chair, members, yes, I can respond to the first part of the question, and I think you, Representative, framed up a lot of really important issues. I can make some initial comments, and then we can do some follow-ups. Yes, Minnesota does have programs to pay family caregivers. Most often in our waivered programs, it's delivered under a program called Consumer-Directed Community Supports. Sometimes we refer to those programs as self-directed programs, and when we use that word kind of in this space, we're talking about the person receiving services or their legal appointee, their guardian, or their conservator actually being the employer of the home care, of the worker that's coming into the home to deliver services. So I like to talk about it as it does put self-directed options are really great. They have a lot more flexibility, and they allow a person to pay a spouse or a caregiver, or in the disability world, a parent can be paid to take care of their minor child in certain circumstances. Provides more flexibility, more control, less sort of there isn't as much presence of the system there, but it also is shifting a significant amount of administrative burden onto the person to develop their own service plan, recruit, train, hire, and fire their staff. But again, in exchange for that, they get what we call budget authority, which means they get a pot of money based on their assessed needs, and a budget for a year, and they can build services and supports and hire whom they wish, and use some financial management services to make sure that they're complying with payroll, taxes, and other employer functions. So we do have that program available under elderly waiver, as well as the disability waivers. Is it an AC as well? No. Okay. And I don't have the breakdown at my fingertips of how many people use that service and program, we can certainly follow up with that data and information. I will say anecdotally, it is more common in the disability community than it is perhaps in the aging caregiver community, and that might be, promoting and helping people understand self-directed options could be a really area of focus. And I think that's one thing Carrie and I have talked a lot of, Director Benson and I have talked a lot about is how can we bring that more in and make sure families know that that's an option for them. There are also some self-directed options available in the personal care assistance program called the PCA Choice program that operates relatively similarly, although there's an agency involved, and we can certainly provide information on that. But we will follow up with the breakdowns on self-directed programs by age and kind of utilization. I will say that one thing that passed in the last session, for which we're very grateful to the legislature, is increasing the overall budget amount for people on EW in terms of people that are choosing to use that self-directed option, that there used to be some level of their budget was a little bit lower, and the legislature authorized us to bring that up to parity with the normal EW case mix caps, which maybe sounds like a small detail, but is a really important incentive so people can self-direct and get access to the same amount of resources as people that are choosing traditional waivered services and programs. And finally, I did want to address the hospital backlog and some of the delays in discharge that we're seeing across our hospital systems, and just want to say that that's an issue I'd be happy to talk more about. It certainly is a really significant and serious problem in our hospital systems for people receiving long-term care, that need long-term care services, need rehab, they're not ready to go home yet. It also occurs in our children's mental health, behavioral health space as well. And so we are working on a variety of things and trying to partner with hospitals and our lead agencies. That's, perhaps another topic we'd be happy to follow up on, but I just wanted to acknowledge and say, yes, we understand, we see that issue too. We're really trying to work across systems, but it's a complex systemic issue to solve. There aren't a lot of short-term fixes, but we definitely are meeting with leaders in the industry and trying to work on that. We also are about to implement our acute care transitions advisory committee that was authorized in the past legislative session to focus on that very issue. So there are a variety of initiatives going on to address that, and certainly happy to have more follow-up on that.
Thank you, Assistant Commissioner. Ms. Schneider?
Thank you, Madam Vice Chair, and thank you for the presentation, ladies. Just a couple of observations and then a question. It was mentioned earlier regarding the general senior hesitation to accept services for a variety of fears. Some of them are misunderstood, and some of them are simply human nature. We don't necessarily look for things until we have some sort of a crisis. I do want us to keep that on our radar, however. I'm thinking back into the late 1980s and early 1990s when home and community-based services were just getting started. And we spent a lot of time and effort and funds on awareness raising. And we used the term early intervention, which was probably a little cumbersome, but I think it's something we need to continue to look at. How early are we getting this message out, and what can we do to somehow overcome some of the hesitation about sharing personal data? I've had elders who say, oh, I don't want anyone messing with my Social Security check. There's just such a disconnect when we start talking about how to pay for things. Second thing, I'm glad you are talking about the self-directed. That's an important piece also to keep on our focus. I'm wondering, and I'm not expecting an answer on this because you said that you would be bringing some additional data points, but at one time I had thought it was kind of a slow uptake on some of the community CDCS services. I don't know if that is still true, but it's something we're going to need to put in the mix. And then finally, on your slide 34, when you were referring to Mark, it looks like between 2020 and 2022, the total reports are jumping up. Do we have any insider knowledge on what might be going on there? Pandemic related? I'm just guessing, just asking. Thank you.
Many great questions, thank you. Anyone want to take a stab?
Madam Chair and
Director
members.
Benson.
Thank you, Madam Chair. Really appreciate all of those points, and I think I'll start with the last one first. And we did see some dips in the number of reports coming in from the public during the pandemic. I think because what we've determined is our best guess is that people weren't going into others' homes as often. And so then, kind of once things were opening back up, we were seeing that uptick. And now calls are surpassing, the average pre-pandemic. And so I think there's more to learn there. But it is also partially because of increased awareness of the mark and the ability to call. And so we are appreciative of that, because we do want, if people suspect something, to call and get that process started, and not hesitate to do that. I think in terms of the self-directed or consumer-directed community supports, we have definitely seen a lower uptake by older adults. We have found that that is largely due to the fact that the budgets were so much less than if you got traditional services. So as Assistant Commissioner Mers noted, with that budget parity, we will hope and really, work on greater, uptick or use of that. And one of the studies that we have linked on the task force website goes to some of your points about earlier intervention. It's very badly named Elderly Waiver Spend Down Study, so who would want to read that? But I encourage you to take a look at that, because it is all about consumer trajectories into our system and some opportunities for us to reach people earlier.
Thank you very much. So I think we're going to move on to public testimony at this point. We probably should have budgeted for an entire session just for DHS and an entire session just for the Department of Health. So our apologies to our friends at the Department of Health if we can't finish today. In terms of public testimony, the first I have is Kathy Kelso and Chris Sundberg from Elder Voice Advocates. Please come to the testifiers table. Please state your name for the record and proceed with your presentation.
Thank you, Madam Vice Chair and members of the committee. I'm Chris Sundberg, and I'm Executive Director of Elder Voice Advocates. And EVA is an advocacy organization that champions solutions that address the needs of seniors and vulnerable adults. We have supported this task force from its beginning, and we look forward to the completion of this critically important task. Our work has offered EVA a unique lens in the many challenges and opportunities we have before us as our population ages. We are struggling with rising costs for our housing, food, and other living expenses. Our transportation system is inadequate, leaving many in isolation. Our healthcare system is often unaffordable, and in some rural areas, it's not available. And this list goes on. But what I'd like to convey to you today is what we ask you to understand about seniors. We want to be seen and included in this planning process, and thank you, we understand that's exactly what's going to happen. We are powerful contributors to our economy and vibrant participants in our society for many years after we turn 65. We want to live in the communities of our choice, and we seniors want to afford our homes, be safe in our communities, have a transportation system that understands our needs, and above all, get the quality care that we have a right to receive. Eventually, some of us will need help from care providers, either in our homes and others in a long-term care setting. But these settings must be more than just a roof over our heads. They must provide compassionate and quality care, and that'll take a number of issues to be resolved to get us to that point. The work of this task force is one of the highest priorities of elder voice advocates. We have been actively engaging with a wide range of senior organizations to make them aware and supportive of this task force. Seniors we have talked to are enthusiastically supportive of this work and have high expectations for a more positive outlook in our coming years. We will continue to communicate broadly to senior groups throughout the state to continue to grow their awareness and encouraging their participation by attending these task force meetings either in person or virtually. Elder Voice Advocates looks forward to being an active partner with all of you, and I believe together we can lead the nation through a well-thought-out plan to tackle our infrastructure and our quality care challenges with innovation, multifaceted solutions. And thank you very much.
Thank you very much, Ms. Sundberg. Next on the list, I have Mr. Leif Greena of the Minneapolis Regional Retirees Council. Welcome. Please state your name for the record and proceed with your presentation.
My name is still Leif Grinna. That was an attempt at humor, apparently. It didn't work. Madam Chair, and members of the committee, my name is Leif Grinna, and I'm 71 years old, and I'm the president of the Minneapolis Regional Retirees Council, a constituent body of the Minneapolis Regional Labor Federation. We are an organization of some 19 local and regional labor union retiree organizations in Hennepin County and the counties north and west of Hennepin. I appreciate very much the opportunity to testify. My testimony might be somewhat different than what you've previously heard. I hope to shed some light, a different perspective on who we are as elders and how we would like to be seen. Aging is a journey along a continuum. As we experience it, our abilities change, but because how we are seen in our society is largely framed by ageism. We are too often seen as being on a fixed point on that continuum. We are too old. But our stories and some interesting data tell a very different story about who we are, what we do, and what we are capable of as we age. When my first grandchild was in elementary school, my wife and I picked him up after school, and there were many gray-haired elders lined up in front of that elementary school just like us. My wife and his other grandfather volunteered to read to students in an after-school program and help them as they learned to read. Elders in Minnesota like us are a huge resource for childcare. Like many, we volunteer in our community. At Loaves and Fishes, we help with the preparation and distribution of meals to families struggling with the results of economic inequality. With few exceptions, our fellow volunteers are elders like us. We are an enormous resource of volunteer labor, deeply engaged in our communities. Where I vote, most of the election judges are elders like me. We are very much engaged in the civic life of our communities. Ageism, though, tells a different story about us. We're dependent, we're in need of support and services, we're old and cranky, sometimes true, absent-minded, befuddled. As a result, we often feel patronized. We are old. It is a frame that implies that we are mentally and physically in need of caring and charity. Age has become an arbitrary criteria for judging ability and fitness for a variety of roles in our communities, regardless of individual mental or physical capability. Ageism is not about who we are. It is a cultural construct that, like racism and sexism, serves to marginalize us politically, socially, and economically. But there is interesting data that tells a different story. We are the largest resource for after-school child care in the state of Minnesota. In a report by the Department of Human Services in 2009, grandparents had the highest rate of child care in the resource of family, friends, and neighbors. itself the highest utilized category of care. We are provide 35% of the child care overall, as high as 56% for the youngest children. We are a huge unpaid workforce in our communities in addition to providing child care. The 2021 AmeriCorps volunteering report noted that in the United States, older adults, 55 and over, had the highest rates of what they define as formal volunteering, meaning within an organization, and informal volunteering, meaning outside of a formal organization. The informal rate for elders 60 to 79 was over 58%. Here in Minnesota, according to a report by Compass, 39% of Minnesota elders volunteer through formal organizations. There are more than 1.6 million Minnesotans over the age of 55. So you do the math and you come up with a volunteer workforce of about 650,000 people. We are very engaged in our democracy in voting and voting administration. Elders vote in a greater percentage than any other demographic age group in the state. Data from the Secretary of State's office shows that voting participation rates rise as people age, reaching a peak of 80% for those between the ages of 70 and 74. In the 2018 general election, around 6 in 10 United States poll workers, 58%, were 61 or older, according to a Pew Research Center analysis of government data from the year's Election Administration and Voting Survey. And as has been said, we have an enormous economic impact, excuse me, we have an enormous economic impact on the state resulting from what we earned during our working years. A Minnesota House Research report for 2023 states for the tax year 2019, Social Security alone brought in $14,619 million to the state of Minnesota. What do we want? Elders want to be appreciated and valued for what we have contributed to our communities and what we continue to contribute. We want to age in the comfort and security of our homes and our communities. We want to have the diversity of elders in terms of capability and engagement in the life of our state recognized, independent of some arbitrary notion of too old. We want to be seen and known for who we are and what we do and where we are on the continuum of aging, and not for the number of times we have been privileged to circle the sun. As we age, we do decline, and we do need support and services, just as we do when we are very young. But Minnesota also needs to see its commitment to our elders as an investment in a valuable and valued population. Thank you.
Thank you very much for your testimony, and I apologize for mispronouncing your name, but thank you for your sense of
That's all right,
humor
I'm
and
used to it.
graciousness. It is appreciated. Next up, I have Michael Landers from the Minnesota Retired State Employee Association. Welcome. Please state your name for the record and proceed.
My name is Mike Landers. I'm the legislative chair of the Minnesota Retired State Employees Association. Madam Chair, members of the task force and task force staff, thank you for the opportunity to speak with you today. I served for 27 years as a finance specialist with the Minnesota Department of Education. I'm here today on behalf of the Minnesota Retired State Employees Association, MRSEA. MRSEA was established in the 1940s, initially as a social organization. However, we expanded our focus in the early 1970s to include advocacy on behalf of our members, particularly in the areas of pensions and group health insurance. We represent thousands of retired state employees from all levels of state government and from all across the state of Minnesota. Like all seniors, our goal is a dignified, fulfilling retirement. For everyone I've talked to, that means aging in place in our own homes. In order to accomplish this, we need to have the wherewithal to remain in our homes. Madam Chair, when we spoke at the first meeting of the task force, you mentioned that the task force would include pensions among its concerns. We're very supportive of the accomplishments of the last session of the legislature in passing the Secure Choice Act, establishing an auto IRA program for employees without any other retirement savings plan. Everyone deserves a dignified, fulfilling retirement. For retired state employees, a large component of their financial well-being is the pensions that they were promised and that they contributed to throughout their entire careers. I'm here today because our members are contracting our board and officers expressing deep concerns about the fact that inflation is eroding the value of their pensions. The cost of living study required by the 2018 pension bill showed that inflation caused a significant loss in purchasing power over a retiree's lifetime. And that was before the recent surge in inflation, which doesn't seem to have an end in sight. Let me give you an example of someone who is covered by the MSRS general plan and retired in 2015. When I add up the differences between their pension cost of living adjustment and the annual rate of inflation between 2017, the first year they were entitled to a COLA, and 2022, the difference is 15.2% over this 5-year period. As of this month, the annual rate of inflation is projected to be 3.2%. If this continues, that will add another 2.2% for a total loss of over 17% over this brief 6-year period. And that's not even compounded. That's straight addition. But this doesn't only affect our members. It affects the economies of every county in Minnesota. Over 88% of all public employees, or all public retirees, are Minnesota residents. In fiscal year 2022, they spent their benefits in every county throughout the state of Minnesota from a low of $3.9 million in Traverse County to a high of $865.7 million in Hennepin County, for a state total of $4 billion, and that's in 1 year. As the value of public employee pensions is eroded, it will definitely have an impact on economies throughout the state. According to the February 2023 National Association of State Retirement Administrators, NASRA, brief, Minnesota ranked 46th in the nation in government contributions to pension as a percentage of all state and local government direct spending, 2.39%, while the national average is 5.29%. Our strong and immediate need is to offer some relief to our retirees who are seeing the value of their pensions eroding due to the ravages of inflation. And we propose that the relief should be in the form of additional state funding. If the state of Minnesota just met the national average government contribution to pensions as a percentage of all state and local government direct general spending, and if each plan met its actuarially determined contribution every year, then Minnesota could keep its promise to its retirees of a dignified, fulfilling retirement. And we ask that you support this effort. Thank you for your time and attention. I'd be happy to answer any questions you may have. And Mr. George, I believe I brought that in under 5 minutes as promised.
Well done. Thank you very much for your testimony.
Thank you.
Next up, and I think last on our list of testifiers, is Ann Bussey from the Minnesota Rural Health Advisory Committee. And I understand you've traveled to join us, so thank you for your efforts. Please state your name for the record and proceed with your comments.
Hello. My name is Ann Bussey, and I live in Side Lake, Minnesota, and I'm very grateful to be here. Thank you. Can you hear me all right? Okay. Healthy aging strategies for our rural 65-plus population is my passion, focusing on quality of life outcomes of purpose, personal agency, social engagement and connectedness, activity, and belonging. I would advocate that it is critical to identify these outcomes as our long-term aging outcomes for all aging work. Why am I here today? Because aging in rural communities can be difficult. Let me give you an example. It has been my pleasure over the years to advocate and resource for a fitness program for people 65 and over in Hibbing, Minnesota. In the last 12 years, our program has closed 12 times. The realities of rural communities, our sponsoring local gym went out of business and was torn down. Our local hospital gratefully picked up the program, but then they needed that space for outpatient services. Then we relocated to a gym in a local church, convincing a YMCA in a community 30 miles away to sponsor us. COVID hit, all the gyms closed. Then the Virginia YMCA went out of business, and now we are sponsored by a YMCA in Duluth, Minnesota that is 100 miles away. Our attendance for programming 3 times a week averages over 40 participants, requiring the availability of a full-size gym. And it is difficult ask in most of our rural communities. We don't have available a full-time gym during day hours. Most of our participants only drive during day hours, or they have day-only local licenses. Our school gyms are not available during the day, and we find that we have our populations competing for the same space during the same time. For us in northern Minnesota, it is about planning our communities as the fundamental context for aging and diversity, and I'm not hearing that today. Rural realities of distance, transportation challenges, financial constraints, poor housing and outdated built environments, diminished health care, limited access to broadband and connectivity, and the predominant aging narrative are contributing barriers that our aging adult experience every day. And Yasher, let's not forget about winter too. I am going to make a bold statement. It is not an option to age well in many of our rural communities. Our rural economic strategies focus on the recruitment of families with children to sustain our communities, while inadvertently ignoring or minimizing the contributions of our aging population. As the task force finds its way to achieve its mission and vision, I would like to emphasize that this is not only about the viability of health care in the 30% of our aging population that live in assisted living, long-term care, or receive community supports and services. That is our aging focus. 70% of us are out there aging on our own. You have reviewed the demographics. I'm not going to repeat them today, but I would like to engage you with the facts, highlight aging women in Minnesota. Nationally, the ratios of women to men increase with age. 125 women to 100 men at age 65 and 178 women to 100 men at age 85 and over. 70% of our aging women live in greater Minnesota, with more than half of aging women 85 and over living alone. Ageism and sexism results in 2 times more older women living in poverty than men, with 33% of Minnesota women relying exclusively on Social Security compared to 17% of men. As an aging woman, these statistics are a concern for me. When people ask me about aging in Minnesota, I say it is about rural and women living alone, often in poverty. The data supporting my remarks today comes from the Aging in Minnesota fact sheet, which I see was distributed as part of the information today. And it accompanied this task force to create you. It was developed through Project REACH, and I could not advance the policy proposal that I did on digital inclusion and literacy unless I addressed the narrative. And so it was an afterthought as part of that program to put this fact sheet together. And I think it has made an impact on how we think about aging. that aging is a lot more than what we typically talk about and what has been the conversation here today. A couple of quotes from women in northern Minnesota. It is so disappointing that there are few to no scheduled activity for us during day hours. All community activities are scheduled after 4:30 p.m. Parking and access to our old buildings is difficult, especially in winter months and in the dark. Where can we walk in our community, especially during the winter? In Hibbing, Minnesota, there is no place to walk in the winter. Additionally, a What Matters survey that we did with the Area Agency on Aging in Northeast Minnesota identified 4 top priorities: communities that offer multiple opportunities for activity and socializing, communities that have access to the internet, as well as opportunities for technology, instruction, and assistance. And I would just like to note that recent data from the Digital Equity Plan indicates that modern elders living in rural areas are the most often left behind with digital literacy and digital inclusion. Communities with adequate public transportation, and communities that encourage participation of seniors. That is what matters to seniors, matters to our communities. We are always a focus group and rarely a stakeholder. Other people make decisions for our population, people that are under 65. As a modern elder, I appreciate the opportunity to visit with you today. Thank you.
Thank you very much for your testimony. Well, we've come to time, everyone. I want to thank testimony and presentation from DHS and our public testifiers. Thanks to everyone for being here and for the task force. Particularly want to thank our friends from MDH for their patience, and we look forward to their presentation. Our next meeting is Tuesday, October 10th. And with that, we are adjourned.